call upon Dr. Manoj to tell us what to do when we glaucoma specialists really don't know what to do, and that is in a blebitis, post-strab infection. Manoj is a VR surgeon with us in Chaitanya, Trivandrum. I don't think anybody in Kerala is left without knowing about him. Go ahead, Manoj, please.
Thank you, Dr. Thomas, for giving me this opportunity. I'm a little misfit here in this glaucoma IC, but always nice to help the department because they always do us a lot of favor managing all our glaucomas. So my talk will be on blood-related infection. And blood-related infection is a late complication of trabeculectomy. And broadly, this can be classified as blebitis and blood-related endophthalmitis. If you look into the literature, the incidence of blood-related infection is in the range of 0.4 to 6.9%. The collaborative blood-related infection study reported a 5-year cumulative incidence of around 2%. There has been a decrease in the incidence of blood-related infection, and this is mostly because of the refinement in the surgical techniques. Now, some people have classified blood-related infection as early and late. The cutoff period is somewhere between 4 to 6 weeks. Investigators have proposed a classification system for blood-related infection. Stage 1 is when there is typical blebitis. The bleb involvement is apparent with the erythema around the bleb and a milky white appearance of the bleb with loss of clarity. Stage 2 is when there is anterior segment involvement in the form of hypopyon, and stage 3 is when there is cellular infiltration of the vitreous. The Japanese Glaucoma Society further classified stage 3 into 3A and 3B. 3A when there is mild vitreous involvement and 3B when there is marked vitreous involvement. And this is based on both clinical and ultrasonographic findings. So the most important thing that we have to remember is that we need to suspect this problem. Pick this up quite early because the symptoms are very, very subtle. Patients may have just a redness, mild redness, discharge, and foreign body sensation. The bleb appearance gives off the clinical picture. You have a nice whitish looking bleb with a lot of congestion around. The transparency of the bleb is lost. Blebitis often is the first form of the disease, and this actually progresses to blood-related endophthalmitis very soon. Defective vision and floaters will actually follow later on. If you look at the risk factors of blood-related infection, there's a whole big list, right from systemic factors to use of topical steroids, antibiotics, and adnexal problems, and also various blood-related issues. Blood leaks seems to be the most important predisposing factor. This analysis from the glaucoma clinic at Arvind Tirunelveli, they found that when it's an early blebitis, it was commonly associated with coexistent lid pathologies. And when it was a late onset blebitis, it is mostly related to blood leaks. The collaborative blood-related infection study also reported that the incidence of blood-related infection was more when there are blood leaks as compared to those eyes where the blood leaks were not documented. Also, people have looked at whether there's a difference between fornix and limbal-based flaps. The collaborative blood-related infection study did not find a difference. Augmented traps definitely carry an increased risk. Both mitomycin C as well as 5-fluorouracil have been implicated. Though there's no difference between the two data, there's some studies which have shown that mitomycin may be slightly having a higher risk. Blood manipulation, suture lysis, blood needling, autologous blood injection, compression sutures, blood revision, all these are known risk factors for blood-related infection. Some people have argued that these manipulations happen months before the actual onset of endophthalmitis, and it may not be related, but the association seems to be very strong. Again, is combined surgery a risk factor for blood-related infection? The collaborative study did not find any difference between trabeculectomy and combined surgeries. Tube versus trap data, I think Dr. Kiran showed partly this data. There's no major difference between the tube and the trap data. However, there is a recent review which commented that the following tube shunt surgery, the reported onset of endophthalmitis appeared a little earlier when compared to those following trabeculectomy. Now, if you look at the spectrum of organism, this is from the West. This data. Streptococcus seems to be the most common organism implicated. Following that is Staphylococcus, Enterococcus, and Klebsiella. The spectrum seems to be a little variable. It depends on the stage of the disease. The spectrum changes, and again, in early blood-related infection, it is mostly Staphylococcus which is implicated, and in late ones, it could be Streptococcus or gram-negative organisms. Also, problems like if you have a nasolacrimal duct obstruction, the commonest organism could be pneumococcus. So, other associated pathologies also can help us identify what the possible organism. One needs to remember that the spectrum is very different from the cataract post-operative endophthalmitis. Culture negativity, it's in the range of 21 to 86% in the reported literature. Indian data, it is even more higher. So one needs to send the samples to a very dedicated ocular microbiology lab to have a better pickup. PCR is a useful technique because the sensitivity definitely is better with PCR. We should also be aware that the antibiotic sensitivity spectrum is changing in India because of the prolific use of fluoroquinolones. In fact, a glaucoma study from Tirunelveli showed that most of these organisms were sensitive to the older chloramphenicol as compared to the newer fluoroquinolones. This is a patient, 55-year-old lady who underwent mitomycin trap for primary open-angle glaucoma and had a good initial post-operative outcome. And 2 months after, the patient came with a visual acuity of hand movements. As you can see, the anterior chamber, there is hypopyon at initial presentation. We did a B scan, and ultrasound did not show any evidence of any vitreous exudates. So we started treating this as a typical case of blebitis. But on day 3, the ultrasound started showing some changes. You see vitreous exudates appearing, and also the RC is kind of thickening. And at this point, we decided the patient has moved from stage 1 to stage 2, and we gave an intravitreal. And this is stage, on day 5, again, you see there is still increase in exudates and increased thickening, and patient received yet another intravitreal injection. Always one needs to take conjunctival culture in these patients. As I said before, sometimes these blebitis are commonly associated with lid adnexial pathologies. So in this case here, it grew Staphylococcus. The vitreous tap was sterile in both the occasions. PCR was negative for bacteria and fungus. Fortunately for us, the patient did well after those 2 injections. And these are pictures on the 20th day. The patient's visual acuity regained to 6.9. The intraocular pressure was 9 millimeters of mercury. So in a nutshell, the management depends on the stage of the disease. In stage 1, topical and periocular antibiotics are good enough. Typically, we use fortified vancomycin and ceftazidime. But in stage 2, one could add along with this oral or parenteral antibiotics. And stage 3, obviously, we need to take a vitreous tap, give intravitreal antibiotics and vitrectomy. There is a growing support for early vitrectomy in these eyes. There is a role for steroids in these eyes, as the collaborative blood-related study used corticosteroids both systemically and locally in both stage 3A and 3B and found favorable results. In terms of early vitrectomy, the data is a little divided as of now, though we tend to do early vitrectomy in these eyes. If you look at the data, there's no big difference between the initial intravitreal injection versus the early vitrectomy group. There are some studies which have shown that that vitrectomy group actually had a worse outcome. Anyway, these eyes definitely have persistence of infection. These eyes require retreatment. 35 to 40% of patients who had an initial intravitreal injections require vitrectomy, and nearly 20% of patients who had a vitrectomy often require a second vitrectomy. Some of these eyes may need the bleb, better bleb management here, scleral patch graft, or sometimes even excision of the bleb. Removing these mini shunts and all that, whenever it's a controversial thing, some people believe that it's a reservoir for offending organisms. Visual outcomes, blebitis usually minimally affects the visual function, but if you have blood-related endophthalmitis, the outcomes can be bad. Now, in one series, nearly 10% of eyes had no light perception and nearly 8% of eyes had to be enucleated. Stage 3 and positive cultures were significant risk factors for poor outcomes. And with respect to IOP control, again, the collaborative study found that stage 3 was a poor prognostic factor for increased IOP. So to conclude, the incidence of blood-brain infection may be less these days, but blood leaks, mitomycin traps, young patients, and systemic disease like diabetes are predisposing factors. Early diagnosis is crucial. If you get to treat this patient at blebitis stage, you could prevent blood-brain endophthalmitis. Aggressive management is the rule. It's not like cataract. You cannot apply EVS guidelines to this. The organisms are different, and early vitrectomy concept seems to be safe and catching up. Thank you.
Thank you, Manoj. Manoj, one query. We glaucoma specialists would be the first one to see any sign of this. At what point should we get the VR specialist involved?
I think right at the time of blebitis, whenever you suspect blebitis, I think you should send the patient to the VR surgeon for an opinion, because I think we would at least do an ultrasound, pick up vitreous opacities, and probably also kind of warn the patient that about the symptoms. And I think at that stage, if you can pick up patients at that stage and maybe overtreat a bit, I think we can prevent endophthalmitis.
This is one point where we have to be very aggressive, and we see a congested bleb, we tend to add on steroids. We see a congested bleb, make sure that the bleb contents are not turbid. You may see small hypoparathyroid-like levels inside the bleb. And early treatment. This particular patient that Manoj talked about, I saw her day before yesterday, or rather last week. 6 weeks, no treatment, nothing, not even topical lubricants, and she's happy 1.5 years down the line. And if we had missed out on a couple of days more, the story would have been different. Thank you, Manoj.
What is the first line of antibiotics that you use when you see blebitis?
Yeah, normally it's fortified vancomycin and ceftazidime is what we generally advise.
Just like you would do in the
just like
cases.
like an endophthalmitis.
Anybody with any further opinions need to discuss? We got about 10 minutes time. Ronnie, what's your take? You're from SN.
Yeah, so for us, the moment we see a blebitis, our protocol is that the patient is seen twice a day, every day, either admitted or should come morning and evening, because if they're in stage 1 where the infection is restricted to the bleb, they do very well with aggressive topical therapy. But the moment you have stage 2, some amount of anterior chamber involvement, and stage 3 is of course entirely your purview. So you have to be very, very aggressive, and this is again one situation where we give systemic antibiotics. We give oral systemic antibiotics to start with, and if necessary, IV antibiotics also. Just one thing that, with experience or unfortunately with experience, is that kids who have a URI, early post-op, this is a major issue, because that pneumococcus just goes up and you land up with very, very bad bleb infections. So otherwise, hope and pray it doesn't happen.
Yeah, I agree. Which systemic would you go for? And Saju, I just noticed you. Another VR surgeon, one more opinion. Which systemic would you go for when you're giving an oral in the early sitting?
So typically any broad spectrum will do. So typically in the early spectrum, we just give anything broad spectrum. We've anyway taken a culture and a swab, and then looking at that, but the next day we change if required.
We admitted all our blebitis. We didn't even consider outpatient follow-up. Two times a day is good enough, because we see them only 2 times a day finally.
Yeah, so sometimes, I mean, if they can't come, also ensure that they come morning and evening. If they can't get admitted, so that's the reason we give them that. We don't give an option, but otherwise we make sure we see them twice.
The only thing that I want to add is topical, moxifloxacin may not be enough, because now most of us may think that just putting them on frequent moxifloxacin may help. Because if we look at the spectrum, it's looks like most of these patients are kind of resistant to that. So it's always better that you change your antibiotic.
The same question I was about to ask is whether there is any role for intracameral moxifloxacin when it is limited to anterior chamber and Bleb only. So Bleb, it may not help, no? Moxifloxacin intracameral?
Intracameral, I'm not sure whether that's going to be of help, but at least in a stage 2, we would like to, we should add parenteral antibiotics. And I think moxifloxacin, if possible, should be avoided, is what I feel.
I also think that going in intracameral, you might just be the tipping point to send it to the posterior chamber. So it's probably better not to enter.
Stage 1 topical is enough. So, and once you reach stage 2, we want a depot there. So once you put something into the vitreous, it's there for 3-4 days. Once you put something in the anterior chamber, it's gone in about half an hour. So if you're putting anything into the eye, it's intravitreal.